Thank you very much. And thank you to my colleagues who have gone before. Donald Rumsfeld, apart from leaving us with a couple of wars that we could probably have done without, has left us with a lot of interesting quotes, and I've put one here. As you know, you go to war with the army you have, not the army you might want or wish to have at a later time. And I don't like to use a war metaphor when we're talking about healthcare, of course, but this is kind of what we have been focusing on in the ASSIST project and the predecessor HCI project and the predecessor quality assurance project before that, is working with the workforce that you have right there on the ground at that particular time and trying to get the most in terms of productivity and engagement to improve the quality of the services that are provided so that we can see improvements in healthcare outcomes. And as Rashad was saying, I mean, that's really where we have been focused. My colleagues from the World Bank and from CapacityPlus have been working at more the policy level and, as well as other things. And they have been working to get more workers to be there to provide those services. We are looking at the health workforce that we have, and there's plenty of evidence that there's just not enough, and there's also plenty of evidence that that situation is not going to change much, as was mentioned before. As we get more health workers, the population keeps increasing as well, and the demand for services also increases. So we've just got to work with what we've got, and that's what we've been trying to do. So a couple of the studies that we have done, actually 3 studies I'm just going to quickly mention. 2 of them were in Uganda, and one of them, it was trying to improve the efficiency of health workers in 14 HIV clinics in Uganda. And this was a few years ago now. It kind of seems a little bit dated, but we actually have been working on those same kind of things since then, but we haven't got the some of the results yet of the studies that we've been doing. So, we were improving, it was an improvement intervention, and it was just very simple things like introducing a triage system. So when patients came in, they could be prioritized, so the less severely in-need patients would not necessarily take up a lot of the time of the healthcare workers that were there. We changed the physical layout, or not we, but the facility managers changed the layout of the clinics, and the staff themselves introduced a rotation system so that there was full coverage of the healthcare workers for the patients that came in on any particular day. Now, and there was the pre-packaging of drugs as well. Now, these are pretty simple interventions, but the thing is, I mean, they weren't doing them before. And if it was such a simple intervention like these look like they are, I mean, they would have been done already if it was easy to do. And so we really went in and we helped them to become empowered to feel that they could actually make these changes themselves. And that's actually a big focus of the ASSIST project and the predecessor projects that we've been working on. The result was shorter waiting times for the patients, and so there was an increase in demand for services. And there were more clients receiving services per staff member. So the efficiency of the staff was actually increased over the period of the intervention. And in these 14 clinics in which this intervention was done, it cost about $16,000. So it was a fairly modest price. And for that, I have the results in terms of dollars saved in terms of staff time. It's because there were different cadres of workers whose time was actually saved. So I kind of reduced it down into a money figure. I know there are flaws in that, but that's what you get. So, these are really simple interventions, and they were actually, in this case, very effective. The other study that we did, or the other intervention that was done, and I helped to do the research on it, was looking at 17 clinics in kind of the same area. And these clinics were working on data management. And again, a very simple list of interventions, really simple stuff, like just better filing systems and training the clinicians on how to fill out their forms a little bit better and actually making sure that they do it. I mean, it's all very well saying this kind of stuff, but then if you just leave them, and there's no checks and balances so that these clinicians kind of feel some accountability, then these changes don't happen. So we helped the clinics, these 17 clinics, put a system in place for accountability so that the clinicians actually had to make good records of their good clinical records of the patients that they saw, and that they could actually retrieve them very easily. So there was no loss of, there was no running around like chickens with their heads cut off, looking for charts and wasting time that way. And we also ensured that the clinical charts were available each time, and we emphasized collecting the data and identifying problems and tracking the changes. So we made sure that the clinicians themselves were actually collecting data on their performance and making sure that it was improving over time. And if it wasn't improving, then they needed to try different changes. And there were 17 clinics, and these some clinicians, some improvement teams, we call them, from each of these clinics got together periodically to discuss the changes that they had implemented and the successes or otherwise that they had seen by implementing these changes. And that sharing also helped kind of the accountability, and also sort of develop this kind of competition between clinics to actually try to see better improvements. So that was a nice thing. And once again, we got reasonably good results with shorter waiting times and improved efficiency of health workers. And again, it really depended on the size of the clinics as to how much improvement or how much time was actually saved. At the bigger clinics, where there were more clinicians working, just small changes made a really big difference. And again, you know, it's a fairly modest price for this intervention, $82,000 for the 17 clinics. The issue with this one is that a lot of the clinics, with the improvement in efficiency, they actually just closed sooner, which was kind of good, that the clinicians themselves had more leisure time. But that wasn't quite the point that we were kind of getting at. But, you know, we're sort of working on those issues as well. You know, but like I was saying, these improvements are, or these interventions are very, very simple, but it's really surprising. I just got back from Indonesia yesterday, and I was talking to some clinicians at hospitals there, and, you know, they're really dedicated to doing the best job that they possibly can for their patients. But when you talk about changing the systems to make things better, more efficient, you know, to make clinics run better, they just feel that they don't know what to do. And these things are just so simple, but they feel that they don't, it's like they're lacking that kind of initiative. I mean, they're great at treating patients, and they really have a dedication to do the best job that they can. But actually, in terms of changing the system, it's frustrating that it's kind of, they just don't feel it in themselves. And, you know, that's kind of where we've been trying to help. Another thing that we've been looking at is health worker engagement, and this is a study that I actually haven't had that much involvement with, but this is something that Alison is going to be talking about in the round table a little bit later on. But we were looking at engagement of health workers in Tanzania, and not only trying to get good measures of engagement to make sure that we have something that we can say, okay, it's improving, or it's, you know, we're not seeing improvements, and what different changes we need to implement to see those improvements. But we were also looking at the characteristics of the patients and their situation that affected their degree of engagement. How am I going to go through those? But we'll be talking about those in the round table as well as the other stuff. Okay, I think that was all that I had to say for now. All right, you're welcome. Thank you.